Good evening, dear students. Today we are continuing with the series which is MCQ Marathon powered by QBank 5, and we are going to talk about anatomy subject this time. As you understand, they are clinical based questions basically for the purpose of preparing you towards next pattern of exam. Though I would say it is not very different pattern of question because long back, that is year 2000, when we were giving our PG entrance exam, even that time such questions used to appear. In AIMS exam, in All India PG exam, that time All India PG was being conducted by AIMS itself, and they used to be USMLE pattern questions. The same pattern you will find even now when we are talking about next exam. But anyhow, next is not coming, might be coming next year itself. But whatever the scenario is, things do not change drastically. So these questions, they will not only be helpful for you in NEET PG exam, INI-CET exam, but also FMGE exam. Let us move on to the Yogesh, Vaishali, Bharat, Mahmood Mehboob Alam. Oh, you are 12th class student. Very good. Budding doctors. Great. Good evening. So let us begin the session, and what you find is in front of you there is a question which is asking us about very favorite topic of the examiners. You see, let me read the question proper, then we can move on to the discussion. It is telling us about the process of oogenesis, the female gametogenesis, where the gamete or the female gamete ovum will be formed. A few million oogonia, or what you call immature germ cells, they are formed intrauterine life because it is a female, and fetal ovary, that is. During oogenesis, some of these cells will be having a dormant stage. Now, female reproductive age, when you talk about the women's reproductive lifespan, that is starting from menarche to menopause, it is say 12 to 40 years, you can take a average. Some of these cells, they will remain dormant till 12 years or maybe 13, 14. Some of them may be staying dormant till 40 years. So which cells are we talking about who is having this dormant feature? I think you must be knowing the answer. If you know the answer, you can put it in the chat. Otherwise, let us discuss the details. Yes, Dr. Anand, good evening. Do you know the answer to this question? Okay, so let us go into the details. We have to understand that there is a difference in gametogenesis of male and female. In female, the gametogenesis begins quite early. Actually, when the baby girl was in mother, intrauterine life, the process would have started. And as we look at the details, you will see in the beginning, you notice that we are having what is called as the primordial germ cells. I will keep giving you some of the answers which the examiner continuously keep asking. Primordial germ cells are derived from. So primordial germ cells are derivative of epiblast cells. It is the epiblast cells which will be forming the primordial germ cell, and primordial germ cell will be forming the gametes. In female, it will be the ovum. In male, it will be the sperm. But this is a discussion on female. So these primordial germ cells before birth itself, that is intrauterine life, when the female baby is within mother, in the uterus, this primordial germ cells, they change and they form oogonium, and then undergoing the process of mitosis. See, you have to understand during gametogenesis you have mitosis as well as meiosis. So it is the process of mitosis. Again a question, which is changing primordial germ cell into oogonium into primary oocyte. Once we have got the primary oocyte, then begins the process of meiosis 1. And you can remember one mnemonic. Your mnemonic is PP1P. Now, what is this? The extension of this mnemonic PP1P? The primary oocyte P is arrested in prophase 1 until puberty is achieved. Let me repeat it. This primary oocyte will be arrested, will remain dormant in prophase 1 and till puberty, because at puberty there will be LH surge, and only after LH surge the meiosis 1 will proceed further. So there is a meiosis 1 arrest. Now let us say the girl has achieved puberty and she is having LH surge and the meiosis 1 proceeds further. Now comes the cell. So you can see here the primary oocyte was arrested in prophase 1, and this was the situation at birth. After puberty, you will see that the second stage will come, which is meiosis 2. And for that purpose, we have got this diagram. Let us repeat the information once before we proceed ahead. What I am trying to tell you is the primary oocyte remain dormant in prophase 1. They will ask you, prophase 1 of meiosis 1 itself is having subsections: leptotene, zygotene, pachytene, diplotene, in which stage it was arrested. So primary oocyte was arrested in prophase 1, and that too in dictyotene stage, which is the other name of diplotene. So diplotene of prophase 1, meiosis 1, and it will remain so until puberty. At puberty there will be LH surge, and then only you will get the secondary oocyte. Once you get the secondary oocyte, again it will be arrested. As it enters meiosis 2, it will be arrested in metaphase 2. So metaphase 2 of meiosis 2, this is the second arrest. It is for the secondary oocyte. So secondary oocyte will remain arrested in metaphase 2 of meiosis 2, and this is the cell which undergoes ovulation. If the sperm is available, then it will undergo fertilization, but most of the time there is no sperm available. Mostly there will be menstruation. So a question comes, it will be asking you, which cell undergoes ovulation or fertilization or menstruation? It's the same cell. Which cell is that? The secondary oocyte arrested in metaphase 2 of meiosis 2 is the one which undergoes ovulation, fertilization or menstruation, and then only there will be further proceeding and you will get what is called as the mature oocyte. But you have to understand that mature oocyte will be a fertilized oocyte. It will have two nuclei, one from the mother of course and one the sperm nucleus. So mature oocyte is already a fertilized oocyte, and of course there will be second polar body released. The first polar body is released after LH surge, and second polar body is released after fertilization. These are all MCQs. We have done almost 6-7 MCQs in this process. So if you go back to your question, this is your question, and I hope now you get your answer perfectly all right. So what do you think? In this particular question, if you are asking oogenesis, the formation of the cells which are remaining dormant 12 to 40 years, it may happen that a primary oocyte arrested in prophase 1 might remain arrested till the last day of the reproductive age, that is 40 years. It can be dormant till 40 years. The primary oocyte arrested in dictyotene phase. Very long diplotene, which is dictyotene. So of course our answer to this particular question is primary oocyte. If there are any issues, kindly mention. There is technical issue. What is the technical issue? Any audio visual problem? Okay, so let us move on to the next question, and as you see, our next question is here. Now, as you will witness, these kind of questions are again frequent. And today's purpose is to orient you towards USMLE pattern type of questions, which used to come in All India PG and AIMS PG 22 years back. I gave such an exam. In my exam, such questions used to come. They used to take inference from USMLE, and the same will happen in the next exam. But I think you know, if you go through the previous year question, it already is happening in All India PG and INI-CET. Even in last year FMGE, we got such questions. So they are not new questions. It is the same information being asked in different kind of pattern. Okay, so what is this about? As you will notice, this time the following is an image of embryo during 3rd week, the time when gastrulation is going on, formation of 3 germ layers, actually 4 germ layers, the 4th being neural crest cell, and it is defect in tunica media of proximal vessels. You have to understand that the embryology which is taught to you in first year MBBS is basic embryology, but when you come to your PG entrance, they will be expecting more than that. And it is the same thing here. Defect in tunica media proximal vessels. Actually, tunica media means the muscle tissue, and that is smooth muscles, and proximal vessels means ascending aorta or pulmonary trunk. That tunica media of the proximal vessels like ascending aorta or pulmonary trunk in the heart comes from neural crest cells. Neural crest cells, number 1. Number 2, if there is a failure of migration of neural crest cell, then there can be problem in the ascending aorta or pulmonary trunk. Number 1. Number 2, rest of the smooth muscles, if you are talking about cardiovascular system, would have come from, it is coming from the lateral plate mesoderm, and lateral plate mesoderm also you have 2 components, dorsal ventral, and the ventral, which is splachno-pleuric lateral plate mesoderm. So it is mentioned that most of the smooth muscles in cardiovascular system are derived from splachno-pleuric intraembryonic mesoderm. Nothing new here, just a kind of a repetition of information in a different way. Now, clinically, there is a case, myoepithelioma, and they are arising from the cells whose structural and functional characteristics are similar to smooth muscle cells, means they are not smooth muscle cells. Myoepitheliocytes are not smooth muscle cells, but they behave like smooth muscle cells. Where do they come from? That is the question. Which of the following marked region? And you see in this diagram, I'll magnify it, a lot of numbering is given. Before we talk about these numbers, before we talk about myoepitheliocytes giving myoepithelioma, let us just briefly revise our embryology. Now, as you do so, you have to understand, when we talk about gastrulation, formation of 3 germ layers, this is the 3 germ layers we are talking about. Post gastrulation means in week number 3 there will be 3 germ layers. Dorsal, there is a amniotic cavity, ventral, there is a yolk sac cavity, and the 3 germ layers are dorsally. You will have the ectoderm, in the middle the mesoderm, and then more ventral is the endoderm. Endoderm will line the yolk sac cavity, and endoderm forms the gut tube. So endoderm is going to form the gut tube. Mesoderm is going to form a lot of tubes. One could be cardiovascular tube, the heart and the blood vessels. And what is ectoderm forming? Ectoderm will be forming the neural tube, that is central nervous system. Now, ectoderm is 2 types. You find that in the mesoderm, there is an axial mesoderm, which we call as notochord. This notochord is now stimulating overlying ectoderm, and that overlying ectoderm becomes neural plate ectoderm. So I'll repeat once again. In the mesoderm, the middle layer, there is axial mesoderm. That axial mesoderm is the notochord. Notochord or the axial mesoderm stimulates the overlying ectoderm and converts it into neural plate. This neural plate ectoderm will then form the neural tube, and neural tube will form central nervous system, that is brain and the spinal cord. Repeated. Central region of the ectoderm becomes neural plate. Ectoderm will form neural tube, will form central nervous system, brain and spinal cord. What about the periphery? In the periphery, you will find there is some ectoderm left, and that is on the right side, left side. That is surface ectoderm. That is surface ectoderm. And surface ectoderm forms a lot of things. One is skin epidermis, skin epithelium. Skin epidermis, skin epithelium. Now, in the skin, there are glands. Around the glands, you have myoepitheliocytes. They are not smooth muscle cells, but behave like smooth muscle cells. And from there, you can have a tumor called mesoepithelioma. That is our question. So, it is the surface ectoderm which is giving us myoepitheliocytes of the glands, like sweat gland, sebaceous gland. The sweat gland and sebaceous gland, they have to secrete, and to squeeze the secretion out, you have some smooth muscle type of cells, means the myoepithelial cells. And these myoepithelial cells are not only in the skin, they can be at other places like around the mammary gland, ducts, glands. So myoepitheliocytes can be seen in the mammary gland also, because mammary gland also is derived from what? Surface ectoderm. So surface ectoderm give you the myoepitheliocytes of the skin, of the mammary gland. They can grow into a tumor, mesoepithelioma. So question is, mesoepithelioma derives itself from the myoepitheliocytes which come from surface ectoderm. Now, you see this central portion, which is neural plate, is forming neural tube, but it can form some smooth muscles also. Now, some students will be confused, how can ectoderm form smooth muscles? But they do. And which smooth muscles are you talking about? So, to tell, from this neuroectoderm, you can have iris muscles. And iris muscles like the sphincter pupillae, dilator pupillae. So, neuroectoderm, neural plate ectoderm can form iris muscles like sphincter pupillae, dilator pupillae. They are smooth muscles for meiosis, mydriasis, but they come from ectoderm, neural plate ectoderm. Otherwise, most of the muscles should come from mesoderm. Now, when you are talking about the smooth muscles, most of the smooth muscles will come from mesoderm, but which part of mesoderm? Now, mesoderm divides itself. As mesoderm is dividing, you will notice that there is one paraxial mesoderm, and that paraxial, para means on the side. So, paraxial mesoderm forms skeletal muscles, and this question is not on skeletal muscles. So, it is on smooth muscle, where the smooth muscles will develop. This is paraxial mesoderm, and paraxial mesoderm do not form the smooth muscles, it forms skeletal muscles. We should not focus here. Then where are the smooth muscles forming? You will see there is a lateral plate mesoderm also, and this lateral plate mesoderm, right side, left side, will form most of the smooth muscles. Now, when you say lateral plate mesoderm will form most of the smooth muscles, will it form the cardiovascular system? Yes, cardiovascular system. The cardiovascular tube, that is the heart and the blood vessels, most of the smooth muscles would come from here. But then there is genitourinary system, and genitourinary system develop from here, which is called as intermediate mesoderm. Intermediate mesoderm will form genitourinary system not only on right side but also on the left side. So, you can see there is a description of intermediate mesoderm, and intermediate mesoderm will form genitourinary system. A question came, it was asking us about detrusor muscle, and detrusor muscle is a smooth muscle in the urinary bladder. What I want you to understand is we can practice 10 MCQs in one MCQ, and this is how you do it. So, detrusor muscle, which is a smooth muscle of urinary bladder, will come from where? Mesoderm. And that genitourinary system, mesoderm, which mesoderm is that? Intermediate mesoderm. So, what is paraxial mesoderm forming? Paraxial mesoderm forms skeletal muscle, no smooth muscle. Then what is intermediate mesoderm forming? Smooth muscles of genitourinary system, like the smooth muscles of kidney system, smooth muscles of vagina. Any smooth muscle related with genital system or urinary system will come from intermediate mesoderm. Then what about the smooth muscles of gut tube? or the cardiovascular tube. May it be the gut tube or may it be the cardiovascular tube. Most of the smooth muscles come from lateral plate mesoderm. But lateral plate mesoderm itself is two types. You are talking about the ventral. This is ventral or splachnopleuric lateral plate mesoderm. Ventral or the splachnopleuric mesoderm, because there is a dorsal also, and dorsal is somatic. So there is a dorsal somatic lateral plate mesoderm, and there is ventral visceral or splanchnic lateral plate mesoderm. This becomes a lot of information, but it is required. By the way, what do you think the answer should be to the question? See, there is one question they have asked earlier, and it used to be a controversial question. What do you think is the answer here? Already answer is given, explanation is also given. So muscles derive from visceral, which is ventral. So ventral, visceral, splanchnic, lateral plate mesoderm. It will form which muscles? And you can see, if you say myoepitheliocytes of skin gland, the question is on mesoepithelioma. So where they come from? Surface ectoderm. So this is surface ectoderm. And what about the iris muscles like sphincter dilator pupillae? Neural plate ectoderm. Neural plate ectoderm. So both of these are ectoderm. And what about the smooth muscles of gut tube? Smooth muscles of gut tube or cardiovascular tube, they would have come from ventral, visceral, lateral plate mesoderm. So this is our answer. Then what about the detrusor? Detrusor is a smooth muscle of urinary bladder, genitourinary system. It would have come from, detrusor will come from intermediate mesoderm. The same thing is written here. Myoepitheliocyte, the surface ectoderm, and iris muscle, sphincter pupillae, dilator pupillae, neural plate ectoderm. What about the detrusor? Detrusor is intermediate mesoderm. So only thing which is the answer here is choice number C. I hope this revises your mesoderm briefly, but the answer, tell me the answer. I have to zoom this diagram actually, otherwise you cannot see. So let us do that. And now, the diagram which I have drawn is similar here. Let us mark the details. You will notice this blue color is ectoderm. And from there, the neural tube has come. This is neural tube. And if you say this is the neural tube, it will form the central nervous system, the brain and spinal cord. Below that is the notochord. This is the notochord, axial mesoderm. So axial mesoderm, notochord, this is neural tube. And what is this blue color which is covering the neural tube? That blue color covering the neural tube is marker 7. That should be our answer because it is the surface ectoderm. So it is the surface ectoderm which will give us myoepitheliocytes, can give us mesoepithelioma. That was a question. And what about these other markings? What is this marking 6? It is amniotic cavity. And marking 8, it is yolk sac cavity. There is a yolk sac cavity, there is the amniotic cavity, there is one more cavity, intraembryonic coelom cavity. Intraembryonic coelomic cavity, dividing lateral plate mesoderm into two parts. And what are the two parts of lateral plate mesoderm? What is this mesoderm? What is this mesoderm? If it is on the side of the axis, we will call this as, let us change the color, we can call this as para-axial mesoderm. This is the one which will form skeletal muscle. So if this is para-axial, what is next to that? That is intermediate mesoderm. So paraxial mesoderm will form skeletal muscles, no smooth muscle. The intermediate mesoderm will form detrusor-like muscle, genitourinary system, smooth muscle. And this is lateral plate mesoderm. Lateral plate mesoderm divides into two because of intraembryonic coelomic cavity. What is dorsal? Dorsal is number 3 and it is somatic lateral plate mesoderm. Doesn't form smooth muscle. Then who form the smooth muscle? The ventral visceral. So this is ventral visceral lateral plate mesoderm which will form smooth muscles of the gut tube, cardiovascular tube. And I haven't talked about neural crest cell yet. What I have seen is that some students, they want to take a shortcut, and shortcut is good, of course, but you will not be able to take shortcut if such type of questions come. So you have to go through the long way, means detailed way. Anyway, so it is asking for mesothelioma, myoepithelioma basically, and myoepitheliocytes and surface ectoderm. So that is marker 7. Marker 7B is your answer. Marker 7. Now I understand okay. I think I don't give any time to you to write down anything in the chat, and that is a good thing actually. More time should be spent upon learning rather than writing things, यहाँ वहाँ की बातें लिखना, उसकी बजाय अगर पढ़ाई करें तो ज़्यादा अच्छा है। मैं यहाँ एक चीज़ बताना चाह रहा हूँ कि एक होता है शॉर्टकट और एक होता है लंबा रास्ता। लंबे रास्ते से चलोगे तो अच्छे डॉक्टर बनोगे, शॉर्टकट तो आपको भी लेना पड़ेगा। लंबे रास्ते से जाकर अगर शॉर्टकट लोगे तो अच्छा रहेगा, लेकिन अगर शॉर्टकट लेके शॉर्टकट लोगे तो अल्ट्रा शॉर्टकट हो जाएगा और डॉक्टर बनते बनते ना जाने क्या बन जाओगे, कंपाउंडर बन जाओगे। तो आप में से कोई भी कंपाउंडर तो नहीं बनना चाहता, इसलिए you have to spend some decent amount of time on learning things and applying them, because maybe it's a circle. We used to get such questions, they changed, again we are coming back to same type of questions. So you must prepare for that. That is our purpose. We should guide you in the right direction. Anyhow, now let us move on to this question. And it is again one of the clinical question. I have taken all these questions from clinics. What I do is I go to Google. In Google I will type case studies. In case studies I will type Kupffer cell sarcoma or Kupffer cell tumor carcinoma, and then I will go through the journals, at least after reading 15 to 20 journals, because these questions are journal based questions and they are prepared by the AIIMS faculty, used to be prepared by AIIMS faculty. Now there will be members who are coming from NIMHANS also, JIPMER also, PGI Chandigarh also, SG PGI Chandigarh, but they will be doing the same thing. Okay, so what is it asking now this time? This time you see they are focusing upon, see, depletion of Kupffer cell happens in advanced cell hepatocellular carcinoma, and maybe the Kupffer cells are depleting, but it is not affecting the progression of the neoplastic activity even after hepatic resection. So a lot of details are there. I have cut short the question here, but now see, when you talk about hepatocellular carcinoma, you will see from the bone marrow a lot of monocyte lineage cells invade the liver. I'll repeat. In hepatocellular carcinoma, you will find from the bone marrow the monocyte lineage cells, they invade the liver. They are asking, hepatocytes means the liver cells themselves which produce bile. They are derived from endoderm of gut tube. That is correct. Foregut. From the foregut, the liver will develop. That is endodermal. The liver parenchyma. Hepatocytes are endodermal. But what about the Kupffer cells? And I think you know the answer. Sometime you will find it is good. It is a good practice. Whenever you find a long question, always start with the last sentence of the question. It might help you sometime to read the answer quickly. So whenever you get a long question, this is not a very long question, but in long questions, which is clinical based questions, sometimes a lot of information is given just to spend time of the student unnecessarily. Means you may be getting answer very quickly if you could read the last sentence and the options. Like in here, hepatocytes are derived from endoderm of foregut, where Kupffer cell will originate from? We know Kupffer cells are basically macrophages, resident macrophages in liver. So where the macrophages come from? Actually, they have migrated from the bone marrow only. They are belonging to this monocyte lineage. So mesoderm. As you understand, the answer here should be mesoderm. Though it is understood that in the beginning, like fetal liver, if it is fetal liver, the liver itself is working like generation of the blood cells and endodermal origin, but in the early stages only. So in the early stages, the liver, which is endodermal, is giving some blood cells. Endoderm of yolk sac give you blood cell. Endoderm of yolk sac give you blood cell. Now somebody might be confusing that how come blood cells are coming from endoderm, because they should come from mesoderm, and that is where there is a blurring of the differentiation, ectoderm, mesoderm, endoderm. Maybe before that there were some precursor cells. So you cannot actually define, but it is written in the books that in the beginning the blood cells, they are coming from endoderm of the yolk sac, from the liver. But if you say Kupffer cell, they definitely belong to monocyte lineage from the bone marrow and must be coming from mesoderm. So choice A is the answer. Let me just see anything in the chat. Okay, so maybe it is all your love which keeps us on our toes and makes us, believe in good things and giving the maximum possible which we can, because eventually, what we leave behind is a legacy, and our legacy is you people. If you become good doctors, यही हमारी गुरु दक्षिणा होगी. हम गुरु दक्षिणा में कुछ नहीं मांगते, हम सिर्फ एक चीज़ मांगते हैं, अच्छे और बहुत अच्छे डॉक्टर बनो, बस उसी से हम खुश हो जाएंगे. So, okay, let us move further. Now, you will not find that these questions are asking you something new, but the pattern of asking questions becomes a little bit elaborate when you get case studies. Now, it's a big, giant case study here. The patient has come to you, but as I told you, it's always better if you could read in a long question, read the last sentence. So let us try to find out if anything, if it gives us anything at all. It is asking obstruction, it is asking us obstruction in which of the following marked structure is the most likely cause of patient's pathology. Look at the markings A, B, C, D. Let me zoom this area. So what are we looking at? I have not read the question at all. I'm just reading the last sentence and the ABCD option. So let me just see that if I could gather some information which might be helping me to get the answer. So what is this marker? A, B, C, D. Immediately you can make out one thing. And what is that one thing? That this is foramen of Monro. Interventricular foramen of Monro, CSF, is pouring from lateral ventricle into third ventricle. This is cerebral aqueduct of Sylvius in the midbrain. So CSF will pass through that. Then it will come to the fourth ventricle, which is marker C, the ventricle of the hindbrain, pons and upper medulla. And then it is reaching this area, and most probably this marker must be talking about central canal in the lower medulla and spinal cord. So one thing is clear, they are asking about something related to CSF flow. Interventricular foramen of Monro, which is under this structure. You know what is this structure here? This structure here, as you notice, is C-shaped fornix, and it is going anterior to foramen, that is interventricular foramen of Monro. This is corpus callosum. This is corpus callosum, this is fornix, this is interventricular foramen of Monro, this is third ventricle, this is the ventricle of the midbrain, aqueduct of Sylvius, this is the fourth ventricle, this is cerebellum posteriorly as the roof of fourth ventricle, this is pons anteriorly at the floor of fourth ventricle, and this is must be the central canal in the lower medulla and spinal cord. Anyway, now we have got what is ABCD, but what is this question about? So then you have done almost 50% of your job. You know, this is something related with the CSF flow. So what is the question then? You have to go very fast. You have to go, and that is what it is very important for you to practice such questions. And there are many sources actually. If you ask me like where should we practice these questions from, nowadays there is no problem, because even PrepLadder is bringing you such questions, or there are other platforms. But USMLE, if you talk about USMLE, Kaplan, QBank, or there are others also, Lecturio, Osmosis. So we get our questions from there also sometime. Sometime we prepare ourselves, or there are books like Board Review Series or High Yield Series or NMS. Students read those books for clearing USMLE, and now maybe you also are preparing for similar pattern question. But anyway, there is no need to go into such elaborate preparation, because maybe we are doing it for you. So we read all those books. Actually, I have been reading those books since last 22 years, and I know what is happening here. So maybe that is good for you, because we will do the homework. You just ये ऐसे है जैसे खीर बनाकर नहीं खिलाएंगे हम आपको. स्पून फीडिंग में तो मैं बिल्कुल भरोसा नहीं करता. मैं एक काम करूँगा, मैं आपको अच्छी वाली सूजी ला के दे दूँगा, अच्छी वाली चीनी, अच्छा वाला दूध, और बताऊँगा कैसे बनानी है. क्या? खीर. वो आपको बनानी होगी, खुद खानी होगी. खीर खिलाना मेरी आदत नहीं है. खीर आपको खुद बना के खानी होगी, पर कैसे बनती है वो बता सकते हैं हम, क्योंकि हम खीर ही तो बना रहे हैं कितने सालों से. एनीवे, ये एक एनालॉजी है. डोंट गो फॉर लिटरल मीनिंग. नाउ let us read the question, and you should be very fast, and that is where, you know, we used to tell read newspaper. This is just like reading newspaper and gathering some of the information which is important for you. सारे समाचार पत्र में सारे न्यूज़ आपके काम के नहीं होते, लेकिन आपकी जो आंखें ना स्कैन करती हैं रडर की तरह, और वो डिटेक्ट करती हैं. डिटेक्ट करो क्या है यहाँ पर. So 3 months, it's basically infant, and brought to physician by mother, and mostly mothers will bring, not the father. Progressive enlargement of his head circumference. Immediately you should think of the commonest things should be thought of first. Maybe hydrocephalus, maybe it is DD, differential diagnosis. Now healthy except for mild episode of tonsillitis. These are distractors. Sometimes they can be helpful, but these are distractors. They waste your time. Be careful. Now, the patient was born at term by cesarean delivery because of a transverse lie. Maybe it is helpful, may not be helpful. And then all developmental milestones are fine, and immunization is fine, and appears well nourished, and then temperature is so and so, no problem. 120 per minute is okay. Even I have 120 per minute, so baby will definitely have this much. And pressure 90-60 is fine, no issue as such, though it is at lower range. And physical examination tends, see, this is what? Tens anterior fontanelle. Hydrocephalus, and now you got your question. Hydrocephalus, tens anterior fontanelle, MRI done, signs of flattening of 4 brain structures. 4 brain structures. Where could be the block? Where could be the block? So, though it is not a very common case, but it is a case of aqueductal stenosis. This is a case of aqueductal ductal stenosis, because it is the aqueductal stenosis which will lead to hydrocephalus, internal hydrocephalus, and flattening of the forebrain structures. Where is aqueduct of Sylvius? It is in the midbrain. If you block it, let me zoom this diagram and you can see for yourself. If I have a blockage at this level, if I am having a blockage at this level, then obviously the CSF, mostly CSF is formed in the lateral ventricles and it must circulate down. So lateral ventricles will be totally filled with CSF, not going further. Aqueductal stenosis, narrowing of aqueduct. So whatever is prior to that, diencephalon and prosencephalon, from inside out they will have flattening effect. That is what the question is asking. So it is a case of aqueductal stenosis. We don't want to spend much time here, but the thing is, or you might be wondering, so this is marker B, that is our answer. You might be wondering that this much of detail we have to study, but in fact whatever we teach you is the same thing. Whatever you read in your BD Chaurasya is the same thing. Only thing is you have to train yourself how to apply that information on your exam pattern. So recently one of my senior faculty member, I did my MD anatomy from AIIMS Delhi. So she had posted one photograph. She is a very lovely lady and very much famous among her students, and lot of people around her standing in a semi-lunar shape. The anatomy department, of course, physiology, pathology, medicine, and all those professors are standing together. And this is the preparation. Not only you need horizontal integration of the subjects like anatomy, physiology, but also vertical integration. And this next exam is all about that. You start with your anatomy, go to physiology, go to pathology, go to medicine, go to radiology, connect everything. Because when a patient comes, you cannot just talk about anatomy of the patient. You cannot talk about physiology of the patient. You cannot just focus upon his radiology. It is a holistic approach. This is holistic approach. And if I am asking you such question, I should be preparing you the similar way, isn't it? So those teachers, like I told you, my senior, they are already preparing you for that. Then only they can ask you such question. This is the way. This is the way. Okay, question number 5. There is no issue. You don't have to read the question at all. You will answer it. Yes, 2024 FMGE, no issues. Yes, they are tougher side questions, but they are not tough as such, Maybe they are appearing tough. Why liver is bypassed at the time of fetal circulation? See, when you talk about the fetal circulation, liver is immature. It is still developing. Lungs are immature. They are still developing. So in fetal circulation, liver is bypassed. It doesn't need much of blood as such. Lungs do not need so much of blood as such. So to bypass liver, you have a ductus venosus, and to bypass the lung, you have two things. One is foramen ovale and the other is ductus arteriosus. So in fetal circulation, you bypass the liver by ductus venosus because it is immature, do not require much of blood. And lungs, they are not oxygenating, so they don't need much of blood. So bypassing through foramen ovale, right atrium, left atrium, and then ductus arteriosus. Cranial neuropore not closed 25th day. Very good, but that is anencephaly. So as I am telling you, sometime if it is a long question, do one thing. Just read the last line of the question go like this. So your diagnosis of the condition, following picture taken by the victim. And what is this picture? So it's a simple question, isn't it? Because you must have seen such questions already in your previous year question practice. So what you notice here is, see, there is a skull defect, cranial vault is missing, brain is small, degenerated, open outside. This is a small degenerated brain which is exposed outside because cranial vault is missing, and anencephaly. Now if this is anencephaly, not only that, you have got another problem. See here, even the vertebral column is open. So let us use the same color. Even the vertebral column is open and neural tube is open, neural tube defect. This is rachis. So one thing is that this patient is having anencephaly, other is the patient is having rachis. Entire neural tube is open, and when entire neural tube is open, you call it as craniorachis. Non-closure of anterior neuropore, which normally should happen at day number 25. So if day number 25 anterior neuropore do not close in the neural tube, there will be open neural tube defect, and posterior neuropore should close by day number 28. Even it has not closed. Anterior neuropore closes at day number 25. If it doesn't close, you have open neural tube defect, anencephaly. And caudal neuropore should close by day number 28 if it is open, rachis, if together, craniorachis. Open neural tube defect. So immediately, I don't need to read the question at all. Maybe it is a trick, and I can immediately mark my answer. My answer is craniorachis, which is combination of anencephaly and rachis. Now let us read the question also. What is the harm in reading the question as well? Because you should be careful. Next time they might change one or two words in the question and you might have mugged up. Whatever the question is, this is the answer. It doesn't work that way. Examiners are very smart. They are smart enough to give this question one time and next time change it slightly, and they know 90% students will immediately mark this, but that would not be the answer. Questions are not repeated. Topics are repeated. So be careful to read the question even if you know the answer. Might be some glitch, might be some thing in, some clue in the question which will change your answer. So just read the question. As you see, it is a 27-year-old female sent out from the village. She came to the court for justice, and you are a forensic investigator and government service. You are involved in investigating, and then she was pregnant but chose not to take services offered by the villagers and PHC, and then childbirth, stillborn. Most of these babies are stillborn. And then famous traditional healer came, and severe deformities and something wrong with the cranium, and villagers told that baby was cursed. Village, cursed. Such things happen in village quite often. Devil, the baby is a devil. And then send the mother outside, cast her out of her. It's a story basically, but eventually you know what is your answer. But my advice is, always read the full question. Read like a newspaper. You know how to read a newspaper? Do you read the newspaper like you have to remember each and every line in the newspaper? No, you just scan the newspaper and some things will be highlighted automatically. And how do you learn that? By practicing as many MCQs as possible. That is the only advice I give to my students. My advice to students who prepare for their PG entrance exam or FMGE exam is only one. What is that advice? Practice as many MCQs as possible. हाथ में ग्लोब है, उसे बोर्ड में फ्रिक्शन नहीं बनता, क्या हो रहा है? हैंड इंजरी नहीं है, ये बस ऐसे है, इसको पाम रिजेक्शन ग्लव्स कहते हैं और ये अननेसेसरी टच को अवॉइड करने के लिए, मतलब अगर मैं इससे लिख रहा हूँ तो इससे ही मेरे पाम को ना डिटेक्ट करे, क्योंकि वो फिर हिलेगा, पूरा स्क्रीन हिलता है ऐसे ऐसे करके. Palm rejection gloves. Okay, so what is the next question? As you see, again, it's a small question, so we can read the in entirety. 25-year-old boy. Sometime age is important, sex is important, especially if it is pure clinical question like medicine, pediatrics. 25-year-old boy, maybe something to do with the answer, but not in this particular question. So presented with signs of intracranial mass, space occupying lesion. So there is a space occupying lesion, intracranial mass compressing left sided cranial nerves anteriorly. Most of the cranial nerves come anteriorly, only one cranial nerve goes posteriorly. Which cranial nerve goes posteriorly? Eventually it will come anteriorly, but which one goes posteriorly? Let me see. Will you give the answer? Abducens? No, I am asking you the only cranial nerve having exit posteriorly. All cranial nerves come anterior. One goes posterior and then comes anterior. Yes, trochlear, cranial number 4. Correct. That is why it has longest intracranial course. Trochlear nerve is the only cranial nerve with dorsal exit, comes ventral, of course, it has to supply SO4, superior oblique muscle, SO4, superior oblique supplied with trochlear nerve, and it has longest intracranial course. This course is additional. So that they are all MCQs. I teach only in pattern of MCQs. Whatever I speak is a MCQ. Already asked or may be asked in the next coming exam. So, but be careful here, because they are asking cranial nerves anteriorly on the left side, pontomedullary junction, and a cranial nerve which is emerging between pyramid and olive. Now this is medulla. This is medulla. So what is your answer? Which nerve come from medulla? As simple as that. Which is, so between pyramid and olive, which nerve will come? Tell me the answer. What is the answer now? You already have given the answer. Abducent? No. Abducent will be at pontomedullary junction. Yes, dose of folic acid to prevent prophylaxis of neural tube. Yes, it can be 400 microgram per day. Antenatal, perinatal, postnatal. If you are talking about neural tube defects, you want prophylaxis of neural tube defect, you can give 400 microgram of folic acid, prenatal, natal and postnatal. And if you already have a previous history of giving birth to a baby with neural tube defect, you have to increase it. You have to make it maybe 1000 microgram per day. Sometime add more. You can be giving 4 milligram per day. So the physician will decide, but normally you prescribe 400 microgram per day. It can be increased to 4 milligram per day also, if there was some history of giving birth to a baby with neural tube defect earlier. So what do you think is the answer? नहीं ऐसा मत बोलो. देखो, ये कुछ नया नहीं है यहाँ पर. कई बार क्या होता है कि हमारी सोच को करेक्ट करने की ज़रूरत होती है, या यूँ कह लो कि अगर आपको दूर का दिखाई नहीं दे रहा, मायोपिया है, तो चश्मा लगाने की ज़रूरत होती है, बस. बाकी कोई गड़बड़ नहीं है, कोई भी गलत नहीं पढ़ा रहा, सब ठीक पढ़ा रहे, पर अप्रोच का फ़र्क हो जाता है. Anyway, Now, it's a very simple question as such, but the thing is how to apply that information. Let me just draw a diagram here. Say this is brainstem, front view of brainstem. You know, brainstem has 3 components. Front view of brainstem, it has 3 components. You know, it is midbrain, followed by pons, followed by medulla oblongata. So this will be the pontomedullary junction. Pontomedullary junction. Now, cranial nerve number 3 to 12 come from brainstem. Cranial nerve number 3 to 12 come from brainstem. They are all MCQs. In the last 20 years, all these MCQs have come. So cranial number 3 to 12 will come from the brainstem. Where number 3 will come from? Now number 3 and number 4, they will be coming from the midbrain. Now if number 3, 4 come from the midbrain, what about number 5? Number 5 will come from the pons. So number 5 will come from the pons. And what about number 6, 7, 8? They come from pontomedullary junction. Say this is the midline of the body. That is midline of the body, front view. So right side of the brain, left side of the brain. The problem is on the left side of the brain and anteriorly. These nerves all come anteriorly except the 4th, because it is the only cranial nerve with the dorsal exit. So only 4th nerve goes posterior, otherwise all of them come anterior except trochlear. So where is this nerve number 5, 6, 7 coming from? 5 is from the pons, number 6, number 7, number 8. They come from pontomedullary junction. Now if number 6, 7, 8 come from pontomedullary junction, what about the number 9, 10, 11, 12? They come from the medulla oblongata. So where exactly they come from? In medulla oblongata. In medulla oblongata, if you look from the front view, you'll find that there is an elevation which is called as pyramid near the midline, and then laterally you have a structure called olive. This is olive. So this is the olive, and then you also have pyramid. Let me just zoom this area, and as you see, what I'm talking about is front view medulla oblongata, and we want to talk about the number 9, 10, 11, 12, and this is pyramid near the midline, and this is olive. You will see in the number 9, 10 and 11, the number 9, 10, 11. Now number 9, 10 and 11, they come posterolateral to the olive. Posterolateral to olive. If 9, 10, 11 come from the medulla oblongata, posterolateral to the olive, where is 12th? That is your question asking. 12th nerve exits between pyramid and the olive. Pyramid and the olive. And this was compressed on the left side. That was the question. So your question was on a nerve exiting between pyramid olive on the left side, compressed by a mass, and what is this nerve? Let me take a transverse section here. You take a transverse section here, and in the transverse section show the 12th nerve again. And as you do that, you will see this is the diagram. Before you look at this, you see this diagram, and this is a transverse section. As you look at this transverse section, you will find this is 4th ventricle posteriorly, and this will be anteriorly. Anteriorly, you will see a medial projection which is on both sides, the pyramid, and then laterally you have another projection which is the olive. This is the olive. Olive is a projection because of olivary nucleus. There's an olivary nucleus which produces this elevation, so that is olive. So what is between olive and pyramid? 12th nerve. Now, what is the use of knowing that this 12th nerve is coming and exiting between pyramid and olive? And especially which one was compressed? It is looking from, say, inferior view. If it is inferior view, then left hypoglossal nerve was compressed. Where is the hypoglossal nucleus, 12th nucleus? 12th nucleus is at the floor of 4th ventricle in the medulla oblongata. So 12th nucleus is in the medulla oblongata at the floor of the fourth ventricle, and this is the axons. Axons make the nerve, neuron bodies make the nucleus, neuron bodies will make the nucleus, axons will make the nerve, and this nerve is exiting between pyramid and olive. Now, what will happen if there is a medial medullary syndrome? You know, this area is supplied by anterior spinal artery. This area is supplied by anterior spinal artery. If there is an anterior spinal artery block, there will be a medial medullary syndrome. Tell the three clinical features. One you already know. So there was a block in the anterior spinal artery leading to medial medullary syndrome, and you will have some clinical features. Tell me one of them. I'll add two. Tell me. 12th nerve is gone, so hypoglossal nerve is gone. So lower motor neuron lesion for 12th nerve. This is lower motor neuron. Upper motor neurons are in the cerebrum. Lower motor neurons are in the brainstem. Upper motor neuron, cerebrum. Lower motor neuron in the brainstem. This is element type of lesion for 12th nerve. So ipsilateral tongue palsy. If it is right-sided problem, the right half of the tongue muscles will be paralyzed. What will happen if right-sided hypoglossal nerve is not working? The left-sided genioglossus become more powerful, where the tongue will deviate. Bulbar palsy, yes, where the tongue will deviate. So if I have right-sided anterior spinal artery block, right-sided medial medullary syndrome, right-sided element palsy of 12th nerve, right half of tongue muscles paralyzed, the left genioglossus become more powerful and keep pulling the tongue to the same side of lesion. Tongue will deviate to same side of lesion. There will be two more problems. What are the two more problems? See, pyramidal tract is also compromised, and this is what you call as medial lemniscus is also compromised. So when the medial lemniscus is compromised, or when the pyramidal tract is compromised, what is the problem? Problems will be contralateral. Problems will be contralateral. So what contralateral problem will be there? If pyramidal tract is compromised, corticospinal tract injury, there will be contralateral spastic paralysis of the body. If it is right medial medullary syndrome, there will be left-sided upper limb, trunk, lower limb spastic paralysis, because this is UMN fibers. They come from cerebrum, UMN fibers. They come from cerebrum UMN fibers and they have been compromised. So pyramidal tract lesion will result in contralateral spastic paralysis. And what about the medial lemniscus? Medial lemniscus is the continuation of dorsal column. Dorsal column, medial lemniscal system. But the crossing has already happened. The crossing has already happened. Is it? Is it? This is 12th nucleus. It is lower medulla. It is 12th nucleus, it is lower medulla, or you can say junction of middle and lower medulla. The sensory decussation is ipsilateral basically, but then if it is after sensory decussation, or simply, I am not going to much detail of neuroanatomy here, take it from me, if medial lemniscus is compromised on right side, problem will come on the left side. Contralateral loss of 5 sensations carried by dorsal column medial lemniscal system. So what are the 5 sensations carried by dorsal column medial lemniscal system? They are pressure, touch, vibration, stenosis, conscious proprioception. I'll repeat it. And in this process, we are doing some 10-12 MCQs already. So if there is right-sided medial medullary syndrome, lesion of medial lemniscus, which 5 sensation will be lost? Contralateral, carried by dorsal column medial lemniscal system. So which 5 sensations? Pressure, touch, vibration, stenosis, conscious proprioception. Anyway, let us go back to the question. And before you go to the question, I'll just quickly show you this diagram, because nowadays they give you these diagrams also, and to identify some of the nerves. All the 12 cranial nerves are available. So if all the 12 cranial nerves are available, let us use this pen. Cranial number 1 coming from the roof of nasal cavity and synapsing in the olfactory bulb. This is inferior view of the brain. Inferior view of the brain. Patient is lying like this, inferior view of the brain. So from the nose, cranial number 1 will come to olfactory bulb. This is the olfactory bulb. Cranial number 1, olfactory tract. This is number 1. From the orbit, you will have optic nerve, number 2. So this is optic nerve. This is cranial number 2, and this is optic chiasma. Then you will have the optic tract. So the number 2. Otherwise, the number 3 to 12 come from brainstem. The number 3 to 12 come from the brainstem. Let us zoom this little bit if possible, and you will notice that now, where is the number 3 coming from? The number 3 and 4 should come from the midbrain. Yes, but where is it? See, nerve number 3, oculomotor nerve, is here. This is number 3 coming anteriorly from the midbrain. Midbrain will also give number 4. Number 3, 4 come from midbrain, but fourth nerve goes dorsal and comes ventral. Only cranial nerve with dorsal exit is trochlear. One more thing about trochlear, thinnest cranial nerve. Thinnest cranial nerve. See, it is very thin, very thin. If trochlear nerve is the thinnest, which is the thickest? Thickest is trigeminal. 1, 2, 3. Trigeminal. Lot of axons, trigeminal, maxillary division, ophthalmic division, mandibular division, 3 division bringing lot of axon. Thickest cranial nerve is trigeminal, thinnest cranial nerve is trochlear. And where is trigeminal nerve coming from? Pons. It has most of its nuclei in the pons. Now, 5th is from the pons. 6th is from where? Now, number 6, 7, 8, pontomedullary junction. Now, number 6, 7, 8. Now, number 6, 7, and 8 from the pontomedullary junction. This is the pontomedullary junction. Now, if it is 6th nerve, 7th nerve, 8th nerve at the pontomedullary junction, where is the number 9? Last 4 cranial nerve from the medulla oblongata, which is 9, 10, 11, 12. So where is 9? 9 is here. This is 9. This is 9. So you mean to say now number 9 is coming from medulla oblongata? Yes, now number 9 is coming from medulla oblongata, and below that rootlets of 10th nerve. So if it is 9, this is rootlet of 10. Now if this is 10, where is 11? Recently, Gray's Anatomy says 11th nerve, cranial part of 11th nerve is question mark. It may or may not be exiting. If 11th nerve cranial part is may or may not be exiting, then what is that we were always talking about? Maybe it is a part of vagus. So cranial accessory nerve is a part of vagus. Yes. Some books says like that. Otherwise, you can tell that along with the vagus nerve runs cranial accessory nerve also. Now, 11th nerve has 2 parts. The cranial accessory, let me change the color. Say it is cranial accessory, and this is spinal accessory. So there is a spinal accessory, there is a cranial accessory. Together they are 11th nerve. Cranial accessory come from the medulla. Spinal accessory come from the spinal cord. Together they will make the accessory nerve, 11th nerve. Some books say there is no cranial accessory nerve. It is just a part of 10th nerve. It runs with 10th nerve, whatever the thing is. But they are running posterior to olive, posterolateral to olive. So where is olive? If you look for the olive, let us draw it. Maybe we can use this color. So this is the olive here. This is the olive. Now if this is the olive, let me show the pyramid also. This is the pyramid anteriorly, and then this is the olive posteriorly. So you mean to say the number 9, 10, 11 come posterolateral to olive? Yes, the number 9, 10, 11 come posterolateral to olive. What is between olive and pyramid is this nerve, this nerve. Can you see? Because now I have drawn so much, you may not be able to see, but let me rub it off and you can see now. This nerve here is, the question is upon hypoglossal nerve. So hypoglossal nerve number 12 is sandwiched between pyramid anteriorly and olive posteriorly. So it will be arising somewhere here. This is the place where you will have the 12th nerve. Again, everything overlapping. So let me rub and you can see. Cannot zoom more than this, but this diagram will help you a lot anyhow. So this was your question. You already got your answer. Question was asking a cranial nerve emerging between olive and pyramid. It is 12th nerve and this is your answer. Okay, let me just see the chat. Thinnest nerve with longest intercranial course is trochlear nerve, correct. Trigeminal is thickest cranial nerve, yes. Difference between cranial and spinal accessory. Cranial part of accessory nerve will come from the medulla oblongata along with vagus. Spinal part of accessory nerve will come from spinal cord. And spinal accessory nerve supply two muscles, sternomastoid trapezius. Sternomastoid trapezius supplied by spinal accessory nerve, whereas cranial accessory nerve following the vagus nerve forming vagus accessory complex. Cranial accessory nerve which come from the medulla oblongata follow the vagus nerve forming vagus accessory complex supply muscles of palate, pharynx, larynx. Palate, pharynx, larynx for speech and swallowing. Speech and swallowing. So cranial accessory nerve come from the medulla oblongata, follow the vagus nerve, form the vagus accessory complex to supply muscles of speech, swallowing. The muscle of palate, pharynx, larynx. Whereas cranial, the spinal accessory come from spinal cord. That's why the name spinal accessory. Supplies sternomastoid and trapezius. Okay, explain in brief. That is what I told. Shortcut, long cut. Shortcut, long cut. The story of shortcut and long cut. Anyway, I'll try to be brief. A 6-month-old infant, clinic, complaints of frequent respiratory infection. Respiratory, URI or LRI? Not given. Cleft palate, so must be URI. Difficulty in breathing, delay in growth, defect involving which of the following structure? Patient's underlying condition. Now this is a vague question. This is a vague question. 6-month-old infant, frequent respiratory infection, cleft palate gives some idea, but then difficulty breathing, delay in growth maybe. And this is where you can read the options and that will give you some idea. See, this is a story about neural crest cells. Neural crest cells, the fourth germ layer coming from epiblast. Neural crest cells are fourth germ layer coming from epiblast and they are migratory in nature. They migrate throughout the body. Neural crest cells are the fourth germ layer coming from epiblast. They are migratory in nature. They migrate throughout the body, and failure of migration of neural crest cell can produce problems like DiGeorge syndrome. DiGeorge syndrome. Neural crest cell, if they do not migrate to pharyngeal pouches will not give proper derivatives, especially PP3. A mnemonic is there, PP3 tip. Now what is this PP3 tip? Pharyngeal pouch 3 gives us thymus and inferior parathyroid. That will be missing. I'll repeat again. This is a vague question. We don't have enough information. I'm getting my information just by the fact they have given cleft palate and pouches. If I find cleft palate and pouches, I think, see, though in clinical practice, the most common things should be considered first in your differential diagnosis, but even in exams, the most commonly asked topic should be considered first in your. Rare things are rarely asked. Rare things rarely happen. Though D. George itself is rare in clinical practice, but it is not rare in your exam. Try to understand. Clinical practice, there will be some things which are common, but everybody will know about them. So they will ask you something which is rare. But then D. George syndrome may be rare in clinical practice, it's not rare in exams. So in exams, it is more common. So think of more common thing first. So this must be a case of D. George syndrome because pouches are given and cleft palate is given. You know, who forms the palate first of all? Who forms the palate? Who forms the maxilla? Who forms the hyoid? Who forms the bones? Here. So remember, maxilla bone, mandible bone, palate bone, they develop in first pharyngeal arch from neural crest cells. I'll repeat. Most of the facial skeleton come from neural crest cell. Hyoid bone come from neural crest cell. I'll repeat. Neural crest cell will form most of the facial skeleton, even the hyoid bone. Even malleus incus and stapes, inner ear, the middle ear ossicles. So middle ear ossicles, malleus incus, stapes, they also come from neural crest cell. Neural crest cell form most of the bones here. There is something wrong with the palate, something wrong with the neural crest cell. But they are not asking about arches here. It is a problem of first arch, of course. But they are not asking about arches here. They are asking about pouches. So which pouch? In D. George syndrome, pouch 3 and 4 both are involved. In D. George syndrome, pouch 3 and 4 both are involved. But if both of them are given, first preference should be for pouch 3. Because most of the cases you will find thymic hypoplasia or thymus may be absent. If thymus is absent, who will train the T cells? And if T cells are not trained, increased cell mediated immunity defects, bacterial infection, protozoal infections. So D. George syndrome, problem of pharyngeal pouch 3, problem of thymus, thymus is missing. So T lymphocytes are missing, and repeated bacterial infections can be there, which is not given too much, just respiratory infections are given. Frequent it is given, so maybe it is because of reduced cell mediated immunity, plus inferior parathyroid is missing. If inferior parathyroid is missing, parathormone is missing. If parathormone is missing, hypocalcemia, and that hypocalcemia might be the cause of delay in growth. So lot of assumptions here, but I don't find any other option here. So now my advice to you is, this D. George syndrome used to come in year 2000 when I gave my PG entrance. And this D. George syndrome is still coming in year 2023. So it has been coming for last 23 years. And I think it will keep coming for next 23 years. When your children will be giving PG entrance exam. कल था आज है और कल भी रहेगा. कल था आज है और कल भी रहेगा. कौन? Medical profession or examiners or D. George syndrome or neural crest cell per questions. Catch 22, yes, pediatrics का भी तो question है ये. Catch 22, कुछ क्रोमोसोम का भी question है. PP3 tip, very good. Okay, so trying to take care of all the questions which are there. As we proceed further, 33-year-old, चलो बच्चों से अब adults पे आ गए. 33-year-old female. See, years, sex are important sometime, especially if it was a pure clinical question. I told you. Emergency. In internship, mostly you will learn in emergency, because in emergency जो सर पे छतरी होती है ना प्रोफेसर की, वो नहीं होती है, प्रोफेसर सो रहे होते हैं इमरजेंसी तुम देखो, जरूरत पड़ेगी तो उठा लेना. Emergency is the place where you learn a lot, but don't experiment too much. You have to wake up your senior if you cannot handle the case. Road traffic accident, frequently they will come, and most of them you will handle. After 15 days of exposure, 16th day you will be totally confident, but not be overconfident. She is found to have pelvic instability. This you cannot handle, you have to call orthopedician. And orthopedician will apply a pelvic binder. You can also apply, no issue. During exploratory surgery, surgeon notices, so now surgery is also going on. So a fracture involving right greater sciatic foramen, okay. Compression of structures passing through. Okay, so you should know what structures pass through greater sciatic foramen. Pelvis, hip bone, right hip bone. Right hip bone, what is not likely to involve? Okay, so this is asking about the structures which are passing through greater sciatic foramen, the right side, and there is a fracture, so it might be dislocated, compressing some of the structure, like mostly it is piriformis muscle pass through greater sciatic notch, a nerve above, a nerve below, superior gluteal nerve, inferior gluteal nerve. Let us draw a diagram. Even pudendal nerve passes there. So let us look at a diagram. Let us look at a person from posterior view. So you are looking at a person from posterior view. Say this is the midline of the body, and this is the sacrum bone, posterior view, coccyx bone, posterior view. Posterior view of sacrum and coccyx, midline of the body. In front of the sacrum, you will find that there is this spinal cord. So spinal cord, especially root value 2, 3, 4, because spinal cord do not reach here. Spinal cord will terminate at L1 level because it is an adult. So it would have stopped at L1 lower border, but the rootlets will come. So the root value S2, 3, 4 will give pudendal nerve of perineum. Pudendal nerve is the nerve of perineum. So S2, 3, 4 pudendal nerve, we want to follow that now. Plus posterior view, so this is right sided gluteal region, posterior view. Right sided gluteal region, the posterior view, and right hip bone. So if it is right hip bone, say this is the right hip bone, greater sciatic notch, lesser sciatic notch. This is greater sciatic notch, this is lesser sciatic notch, and this is ischial spine. Ischial spine. You know, when you give pudendal block, you have to locate the ischial spine because pudendal nerve hooks behind ischial spine. So if this is ischial spine in the right hip bone, posterior view, right hip bone, posterior view, if this is ischial spine, what is this? Greater sciatic foramen. And what is below that? Lesser sciatic foramen. So where is pudendal nerve? Pudendal nerve come from, say, this is S2, S3, S4, anterior primary ramus. All of these are MCQs. All of these are MCQs. Anterior primary ramus of S2, 3, 4. Anterior primary ramus of S2, 3, 4 will give pudendal nerve. Pudendal nerve from the pelvis will go to perineum because it is the nerve of perineum. So as it comes from the pelvis in front of sacrum bone, in the pelvis, it will come to greater sciatic foramen. So pudendal nerve is in the pelvis, will exit the pelvis, passing greater sciatic foramen, come to the gluteal region and passes behind ischial spine. So pudendal nerve is now in gluteal region, means it was in the pelvis, then comes in the gluteal region, short course, and then goes into lesser sciatic notch. And from the lesser sciatic notch, it will go and supply the perineum because it is the nerve of perineum. It will supply skin and skeletal muscle of perineum. Skin and skeletal muscle because it is a somatic nerve. It's a somatic nerve, it will supply the skin and skeletal muscle of the perineum. So this course is important. Whenever you are giving pudendal block, say for episiotomy, for forceps delivery, For forceps delivery or episiotomy, you block the pudendal nerve. And how do you block the pudendal nerve? You palpate for ischial spine. That is the region where you can infiltrate your lignocaine and you can block the pudendal nerve. So course is important. Anyway, what was the question? Question is asking us what all structures pass through the greater sciatic foramen, because they might be compressed. So pudendal nerve can be compressed? Yes, because it passes through the greater sciatic foramen. Okay, what else passes? Pudendal nerve is going to supply perineum, so artery, vein will be there. They will accompany. So which artery, vein will accompany? They are called as the internal pudendal vessels, you can say. Internal pudendal artery, internal pudendal vein. So internal pudendal artery, internal pudendal vein, they will be following this pudendal nerve? Yes. And one nerve also will be additional. So which nerve is additional? Actually, you can remember pin structures. Pin structures, they are passing from greater sciatic notch to lesser sciatic notch, hooking behind ischial spine. Pin structures are passing from greater sciatic notch, lesser sciatic notch, hooking behind ischial spine. What is P for? P is for pudendal nerve. What is I for? Internal pudendal vessels, artery, vein, artery, vein. Okay, internal pudendal vessels. What is N for? N is nerve to obturator internus. Nerve to obturator internus. What is this obturator internus? Obturator internus is a muscle. And where is that muscle? That muscle is actually passing the lesser sciatic notch here. Remember the tendon of obturator internus. Tendon of obturator internus passes the lesser sciatic notch, not the greater sciatic notch. You mean to say pin structures passing from greater to lesser sciatic notch, in that pin structure the N was nerve to obturator internus. So in the greater sciatic notch you have nerve to obturator internus but not the tendon of obturator internus? No, because tendon of obturator internus is in the lesser sciatic notch. So what is there in lesser sciatic notch? In lesser sciatic notch you have tendon of obturator internus and the pin structures. Okay, and which tendon you have in the greater sciatic notch? In the greater sciatic notch we don't have tendon, it is a muscle, and that muscle is piriformis. That is piriformis. So piriformis muscle, belly, yes, muscle belly. This is a tendon, that is a muscle belly, muscle fibers. Okay, so in greater sciatic foramen you have piriformis muscle belly. Yes. Anything else? There are a lot of things. One is the above that superior gluteal nerve and below that inferior gluteal nerve. This much will be enough. So you are telling that in the greater sciatic foramen there will be superior gluteal nerve superior to piriformis. Yes. Inferior gluteal nerve inferior to piriformis. Yes. And inferior to piriformis you will have the pudendal nerve. Yes. Sir, you have missed a very big thing. What about that? Yeah, you tell me. What is that big thing? Tell me. Tell me. Tell me what is a very large thing passing the greater sciatic notch which I have missed. Tell me. बहुत ही मोटी नर्व है. ग्लूटियल रीजन में कौन सी नर्व आती है? एक्सट्रेनो sciatic nerve. Very good. नहीं भाई, femoral nerve anterior thigh. ये ग्लूटियल रीजन है, तो शियाटिक नर्व. ठीक है, शियाटिक नर्व. अब देखो, अब क्लियर हो जाएगा जब मैं आपको डायग्राम दिखाऊंगा, पर डायग्राम से पहले ही यू कैन सी द आंसर. सो देयर इज अ greater sciatic foramen involved, structures in greater sciatic foramen involved, not the structure in the lesser sciatic foramen. So it is asking not likely to be involved, not likely to be involved, and your answer is obturator internus tendon, because obturator internus tendon passes through lesser sciatic notch, not the greater sciatic notch. You mean to say pudendal nerve passes the greater sciatic notch? Not only greater, it passes lesser also. And what about internal pudendal artery? Not only artery but also vein passes both the foramen. What about this inferior gluteal nerve? Not only inferior gluteal nerve but sciatic nerve also passes inferior. So even sciatic nerve passes inferior. Inferior to what? Inferior to piriformis. And what is superior to piriformis? Superior to piriformis is superior gluteal nerve, and answer is obturator internus tendon, choice number D. And you can see the diagram which examiners sometimes give. I really doubt now they will be giving, but they started giving you some dissected specimen, and then they stopped giving dissected specimen because they could realize nobody is answering. They started giving you some dissected specimen, and then they stopped giving you dissected specimen in the PG entrance exam because they realized nobody is answering correct. If nobody is answering correct, then what is the fun in asking the question? So they have stopped. Anyhow, humor aside, so looking at the right sided gluteal region, posterior view, right sided gluteal region, posterior view, not exactly posterior view, but posterolateral, you can say posterolateral, because this is the sacrum bone posteriorly, this is sacrum bone posteriorly, and this is right hip bone, right hip bone. Now I already have drawn this diagram. If you remember, I told you that this will be the greater sciatic foramen above piriformis, and this is, now I change the color, say let us use this color. So this is lesser sciatic foramen. So this is lesser sciatic foramen, lesser sciatic notch. First it is a notch created foramen by some ligaments. So this is greater, this is lesser. And where is ischial spine? This is the ischial spine. This is the ischial spine. So that is ischial spine. Now the thing is, this is piriformis muscle here. This is piriformis. Above that there will be a nerve, superior gluteal nerve, and below that there will be a nerve, that will be inferior gluteal nerve. But not only inferior gluteal nerve, you will have pudendal nerve, the pin structure, nerve to obturator internus, and also sciatic nerve. So which structures pass above the muscle belly of piriformis, superior gluteal nerve, and which structure pass below the piriformis in the greater sciatic foramen? It is sciatic nerve and pudendal nerve and nerve to obturator internus and internal pudendal artery and vein. All those structures will pass here. Then what will be passing here in the lesser sciatic foramen or lesser sciatic notch? In the lesser sciatic foramen, lesser sciatic notch, what will be passing will be the pin structure, and along with pin structure, what else will be passing? So you should know that there will be, let us use some color, this color, hooking behind the ischial spine will be pin structures, and these pin structures come from greater sciatic foramen and enter lesser sciatic foramen. So from there to there, hooking behind ischial spine, that is where you can block the pudendal nerve. Now in the lesser sciatic foramen, you have one additional thing. Not only pin structure will be passing in the lesser sciatic foramen, but one more thing, that is the tendon of obturator internus. So tendon of obturator internus cannot be damaged if there is a fracture involving greater sciatic foramen. That was the question, and this will become more evident when you look at the next diagram, because these questions are frequent questions. So I just want you to be comfortable with the details. As you see, this is again right sided gluteal region, posterior view, right sided gluteal region, posterior view, and you have cut a very large muscle here, that is gluteus maximus. First you cut the gluteus maximus, and what will be deep to gluteus maximus? You have the gluteus medius, which you have cut again. And what is deep to gluteus medius? That is the gluteus minimus. So this is gluteus minimus, and along with gluteus minimus, more anteriorly, you will have tensor fasciolata. So this is gluteus medius, and this is gluteus, so this is gluteus minimus, and this is gluteus medius. The point is that gluteus medius, gluteus minimus, and tensor fasciolata, they are supplied by a nerve which is called as superior gluteal nerve. So this is the superior gluteal nerve passing superior to piriformis muscle, passing superior to piriformis muscle, a superior gluteal nerve supplying three muscles, and the three muscles are gluteus medius, gluteus minimus, tensor fasciae lata. Medius, minimus, tensor fasciae lata, and they have three actions. What are the three actions of superior gluteal nerve supplying three muscles? Mention. Very frequently asked questions. Mention. My question is, superior to piriformis passing, greater sciatic foramen is superior gluteal nerve supplying three muscles, namely gluteus medius, minimus, tensor fasciae lata. So, what are the three functions of these muscles? Very repetitively asked question, at least last 5 years. Last 5 years they have been asking about these muscles. Can you tell me? So, due to the limit of time, I'll tell these three muscles, they do abduction, medial rotation, and pelvic stabilization, especially while walking. So, superior gluteal nerve by supplying three muscles will do three actions. So, what are the three actions of these gluteus medius, minimus, tensor fasciae lata? They are abductors at the hip joint and medial rotator at the hip joint and pelvic stabilization while walking. Now, what is this pelvic stabilization while walking? If they are not working, like you took injection and you are a new learner, you injected into the superior gluteal nerve only and these muscles got paralyzed. This can come as a question. A new learner, a house surgeon intern, very hyperexcited, takes the injection from the nurse. Let me give the injection, nurse. And then you don't do surface marking, you just inject into this nerve, which the superior gluteal nerve. So what happened? Nerve is gone. So these muscles are gone. So one test is positive. Which test is positive? Trendelenburg test is positive. What is this Trendelenburg test is positive? Iatrogenic injury of superior gluteal nerve. Giving injection, you give injection into gluteus medius basically. You should give your injection into gluteus medius. But normally, they can, okay, there's a big muscle mass, let us give it in maximus only. When you are giving in maximus, you might be reaching the superior gluteal nerve. So, these muscles will be paralyzed, especially Trendelenburg test positive means if you have damage right-sided superior gluteal nerve and you ask the patient to stand on the right foot, lift the left foot, what will happen? If you are having right-sided superior gluteal nerve injury, right-sided gluteus medius, minimus, tensor fasciae are not working, and right-sided foot is on the ground, you are asking the patient to lift the left foot, the pelvis will tilt down, left pelvis will tilt down. Normally it is prevented by the right-sided three muscles. So, normally the right-sided gluteus medius, minimus, tensor fasciae lata prevent excessive pelvic tilt, which might happen because of gravity. If you take the foot up, gravity will pull down. If you take the foot up while walking, gravity pulls down. If gravity pulls down, why the foot doesn't fall down? Because you counteract gravity by other sided glutei muscles, medius, minimus, tensor fasciae lata. And if they are not working, excessive pelvic tilt, there will be a lurching gait. Lurching gait, spine will bend. There will be a bending of spine to clear the foot off the ground. That is Trendelenburg test. Anyway, that is another topic of discussion. But can you see one thing here? Can you see that the pin structures are passing here? Let me zoom this area. These are the pin structures. The pin structures are pudendal nerve, nerve to obturator internus, and along with that you will have the internal pudendal artery and vein. So, pudendal nerve, nerve to obturator internus, internal pudendal artery vein passing greater sciatic notch going towards lesser sciatic notch. And in the lesser sciatic notch, if you can see, this is the let me change the color. This is the tendon of obturator internus. This is the tendon of obturator internus. This is obturator internus. But obturator internus muscle is on the obturator foramen, and in the notch you have tendon. So this is obturator internus. You cannot see obturator internus until you remove this large muscle, gluteus maximus. You cut the gluteus maximus, then you see obturator internus, and it is sandwiched between two muscles. What are these two muscles which are superior and inferior? They are called superior inferior gemellus. Superior inferior gemellus. They all insert into greater trochanter of the bone femur. Bone femur, greater trochanter, you find three muscles attaching. Actually, a lot of muscles attached to greater trochanter, but this is right femur posterior view, right femur posterior view, and you see the two gemelli, superior gemellus, inferior gemellus, and obturator internus, they insert into greater trochanter. In the greater trochanter, you also see this muscle inserting, and let us show that, maybe this color, to the tip of greater trochanter, the piriformis muscle. But piriformis muscle come from greater sciatic foramen, whereas the obturator internus come from lesser sciatic foramen. Now, obturator internus come from lesser sciatic foramen, piriformis come from greater sciatic foramen. Which nerve is above piriformis in greater sciatic foramen? Supraglutial nerve. And which nerve is below? That is inferior gluteal nerve supplying gluteus maximus. Inferior gluteal nerve supplying gluteus maximus, and this is the large nerve we were talking about, sciatic nerve. So this is sciatic nerve which is coming from the greater sciatic foramen below piriformis. So below piriformis, which nerves are coming? In the greater sciatic foramen below piriformis are coming inferior gluteal nerve and sciatic nerve and pudendal nerve and nerve to obturator internus. Nerve to obturator internus. But obturator internus is not in the greater sciatic foramen. So I hope that answers our question. Our question is here. It is asking fracture of the greater sciatic foramen. So which structure is not involved? The structure which passes through lesser sciatic foramen. Tendon of obturator internus is not affected. Okay, let us go on to the next question, and it is asking "25-year-old female." Again, age may be important, sex may be important, road traffic accident. All the road traffic accidents have come. Actually, they will ask you such questions because in internship you get such questions, such patients. That is why. And as evidence of fracture spanning greater wing of sphenoid bone. I did my MBBS from Bangalore Medical College, Government Medical College, Bangalore, and any such case, refer to NIMHANS, neurosurgery, neuropsychiatry, neuromedicine. Okay, so greater wing of sphenoid. Foramina within it are involved, left side. So left-sided fracture. Which of the following openings are most likely not involved? Not involved. So what do you think? Let us just first, and these kind of questions come nowadays, matching only 2, only 1 to 3, 1 3, 1 2 4, like that. So you must practice such questions so that you don't waste time on sitting in the exam hall and deciding what should be the answer. You must be very quick once you get your answer. So look inside the cranial cavity. Let us look inside the cranial cavity. So when you are looking inside the cranial cavity, you will have 3 cranial fossa: anterior, middle and posterior. So this is anterior cranial fossa, middle cranial fossa and posterior cranial fossa. Remove the skull cap, remove the brain. Look inside cranial cavity after removing brain. So you'll have anterior, middle, posterior cranial fossa. This is the midline, this is anterior and that is posterior. So let us magnify. As you are looking at the 3 cranial fossas, where is this Sphenoid bone. Sphenoid bone is like a butterfly. Sphenoid bone is like a butterfly. A lot of questions come upon sphenoid bone. So you should have good details. So where is sphenoid bone? Sphenoid bone will have a body. Sphenoid bone will have a body, and this body will be at the floor of anterior, middle and posterior cranial fossa. So this is the body of sphenoid. It's a midline bone, only one. So it is a midline bone and it is having a body. Butterfly will have body and wings. It has a lesser wing, greater wing and a body. This is the body. So where is the body of sphenoid? Body of sphenoid is at the floor of anterior, middle, posterior cranial fossa. And where are the wings? It will have a lesser wing at the floor of anterior cranial fossa. So it has lesser wing at the floor of anterior cranial fossa. Where is the greater wing? Greater wing is at the floor of middle cranial fossa. The greater wing is at the floor of middle cranial fossa. So greater wing of sphenoid, yes, and this is the body of sphenoid, yes. And remember, in the body of sphenoid, in the floor, this is all we are talking about, floor. In the floor of middle cranial fossa, you will have pituitary fossa and pituitary gland. You mean to say pituitary gland is at the floor of middle cranial fossa in the body of sphenoid? Yes, that is where you know the name sella turcica. So sella turcica, okay. Turkish saddle appearance. Sella turcica, Turkish saddle appearance, body of sphenoid at the floor of middle cranial fossa, pituitary gland, fine. What about the openings? The examiner is asking. Remember, in the lesser wing junction with the body, you have optic canal, and in the optic canal passes cranial nerve number 2, the optic nerve coming from the orbit. What is this? This is a defect in lesser wing of sphenoid when it was attaching to body of sphenoid. Optic canal is a defect in the lesser wing of sphenoid when it was attaching to body of sphenoid. Where is it? It is at the floor of anterior cranial fossa. So at the floor of anterior cranial fossa, a defect in the lesser wing is optic canal for the passage of optic nerve, cranial nerve number 2. From the eyeball, you have optic visual information. Optic nerve passes here and then goes to brain. Okay. Then what are the openings in the greater wing? In the greater wing, the openings are, let us choose some black color maybe, ROW. What is this? Rotundum, ovale and spinosum, ROS. What is ROS? Rotundum, foramen rotundum, round foramen, oval foramen and foramen on the spine of sphenoid bone. So you mean to say in the greater wing there are 3 openings? Yes, rotundum, ovale and spinosum, right. What is passing through rotundum, ovale, spinosum? Some trigeminal branches, some trigeminal nerve branches. So rotundum, ovale, spinosum, some trigeminal nerve branches will be passing. Yes. Okay. Where is this foramen lacerum? Foramen lacerum, if you want to see, come to the posterior cranial fossa. In the posterior cranial fossa, you will have what is called as the foramen magnum. And what is foramen magnum? A large foramen, foramen magnum. Okay, where is foramen magnum? It is in the occipital bone. This is occipital bone attaching to body of sphenoid. And when the occipital bone attaches to body of sphenoid, means joint, that is in the posterior cranial fossa. So at the floor of posterior cranial fossa, you have a junction between the occipital bone and body of sphenoid. Spheno-occipital junction. Spheno-occipital junction. At the floor of posterior cranial fossa, this is foramen magnum. And what else in the posterior cranial fossa? In the posterior cranial fossa, we have bone, and that maybe which color should we take? Should be evident enough. Let us take orange color if possible. Petrous temporal bone. Petrous temporal bone. So let me draw it here also. Petrous temporal bone. Inside the petrous temporal bone, you have inner ear and middle ear. So inner ear and middle ear is in the petrous temporal bone. And what is between petrous temporal bone and occipital bone? What is between petrous temporal bone and occipital bone is jugular foramen. And what passes through the jugular foramen? The number 9, 10, 11 and jugular vein, internal jugular vein. So where is jugular foramen? Jugular foramen is between petrous temporal bone and occipital bone. So between petrous temporal bone and occipital bone you have the jugular foramen passing jugular vein, internal jugular vein with the nerve number 9, 10, 11. But where is foramen lacerum? Foramen lacerum is bounded by 3 bones. 3 bones. What is 3 bones? 3 bones. This is foramen lacerum bounded by apex of petrous temporal bone, the occipital bone and the sphenoid bone. So foramen lacerum is bounded by 3 bones, apex of petrous temporal bone and sphenoid bone and the occipital bone. You mean to say the foramen will be something like this, yes, it is like this. It is like this because as I am telling, it is bounded by 3 bones. Which 3? Sphenoid bone and petrous temporal bone and the occipital bone. Once you have this idea, what was their case? Sir, I forgot my case. No, you had a case, there was a question. Yes, I remembered now. NIMHANS. Which patient did you send to NIMHANS? Actually, sir, there was some fracture of the greater wing of sphenoid involving all the foramina. Yes, all the foramina, rotundum, ovale and spinosum. So there was a fracture of the greater wing of sphenoid involving all the foramina, rotundum, ovale, spinosum. Question was asking which is not involved. So if you ask which is not involved, you can answer now. Let me take this here. So what do you think? 25-year-old female, road traffic accident, greater wing of sphenoid involving all the foramina within on left side and which is not involved. So first of all, what is involved? The foramen rotundum is involved and foramen spinosum is involved. So what is not involved? 2 and 4. Why 2? Because optic canal is a defect in the lesser wing of sphenoid, not the greater wing. Okay, what about foramen lacerum? Foramen lacerum is not an opening in the greater wing. Then where is foramen lacerum? Foramen lacerum is just a gap between 3 bones, the sphenoid, the petrous temporal bone and the occipital bone. It is not an opening in greater wing. The problem is with the opening in the greater wing. Okay, so you mean to say 2 and 4 are answers? Yes, 2 and 4 are not involved. That is your answer. Now the purpose of this discussion is simple. I am not telling you anything new. We already teach this. Only the way of asking questions might change. They will create. I remember I used to go to teach in Konasima Institute of Medical Sciences, East Godavari district, Andhra Pradesh, long back. So long back I used to go to Andhra Pradesh, East Godavari district, very green, lush greenery is there. Konasima Institute of Medical Sciences. There was a professor, very old professor, anatomy professor, and he visited a lot of countries and then came back, very old, so just honorary service. He told me one thing, which I took very seriously. He told me, what do you think this USMLE pattern question, whatever they ask, are they real clinical scenarios? They just make questions themselves, and it was true. As you go through USMLE question bank, as you go through board review series, as you go through whatever, they just create some question using anatomy, and it may or may not be clinical scenario. And it's difficult actually to create a question which is clinical and still anatomical. So it is difficult to create such questions, and most of them, they, like, he used to laugh at those questions. What is this? Why do they even make such questions? He used to laugh. So sometimes I laugh at such questions, because you have fabricated them. They are not the real questions. So I try to find the real patients. I told you how. Google search case study fracture greater wing sphenoid, and you will find statistical analysis. Go through those journals, 5 to 10 journals. Authentic information should be there. Then you prepare a question. You are not faking it. Though they say fake it till you make it. Fake it till you make it. Maybe I was also faking in the earlier classes, but now, no. Even after 20 years, if I fake it, then when am I going to make it? So I take the real scenarios. Of course, then I will modify them according to my need, but they are clinical scenarios, okay? And I am hopeful that the examiners who are preparing your next exam, or maybe your people at AIIMS, would be serious enough, like that old professor, anatomy professor. Anyway, okay, let me just go through the chat. Normally in my chat, nobody writing anything, because so much information bombardment, torture is going on. So everybody is like, in pharmacology we used to pith the frog, and when the frog is pithed, then senseless, then there is no time to think and write in chat. नहीं, पेपर मैं नहीं बना सकता, क्योंकि अगर मैं पेपर बनाऊंगा तो मैं पढ़ा नहीं सकता. अब आप डिसाइड करो. पेपर में बना सकता हूँ, मैं वहाँ गुजारिश करूँगा कि मुझे रख लो, तो हो सकता है मुझे रख लें. पहले तो मुझे जाके पोस्ट लेनी पड़ेगी, कि पहले तो मुझे प्रोफेसर बनना पड़ेगा वहाँ जाके. 2-4 साल उनका भरोसा होगा कि ये आदमी भाग नहीं जाएगा, और तब वो फिर हो सकता है मुझे एक क्वेश्चन बनाने दें. तो अच्छा है कि मैं पढ़ाते रहूँ. क्या वहाँ बहुत सारे अच्छे लोग बैठे हुए हैं, धुरंधर. पेपर में बना सकता हूँ, लेकिन बड़ा मुश्किल काम है. वो भी एक स्टोरी है, अभी स्टोरी के लिए टाइम नहीं है. पेपर में एक क्वेश्चन बनाना बड़ा मुश्किल काम है. और मैं आपको ये भी बता दूं कि एक क्वेश्चन के कितने पैसे मिलते हैं, पता है? एक क्वेश्चन बनाने के कितने पैसे मिलते हैं? नहीं सर, अब आप पैसों की बात करने लगे, यहाँ तो रुपए कम पड़ जा रहे हैं. नहीं, मतलब लिटरल है. डॉलर्स बताओ, कितने डॉलर्स मिलते हैं? सर US डॉलर तो डिवैल्यूएशन हो रहा है, मतलब उसका तो खैर वो तो ऊपर जा रहा है, पर इंडियन रुपीस नीचे जा रहा है. डी डॉलराइजेशन हो रहा है. अब लोग कह रहे हैं छोड़ो, US डॉलर में क्या हम डील करेंगे, हम चाइनीज़ युआन का इस्तेमाल करते हैं रशियन ऑयल खरीदने के लिए. तो डी डॉलराइजेशन हो रहा है. एनीवे, कभी कभी एक क्वेश्चन का 1 लाख रुपए मिलता था. आज से 2004 में मैंने एम्स छोड़ा था, 2004 की बात कर रहा हूँ. एक क्वेश्चन का 1 लाख रुपया, अगर अच्छा क्वेश्चन है. अच्छा क्वेश्चन क्या होता है? अच्छा क्वेश्चन वो होता है जिसमें सिर्फ 10% स्टूडेंट आंसर कर पाए और 90% रॉन्ग आंसर करें, वो होता है अच्छा क्वेश्चन. एक अच्छा क्वेश्चन वो है जिसमें 90% स्टूडेंट रॉन्ग आंसर करें और 10% करेक्ट. क्योंकि यही तो है, 2 लाख बच्चे एग्ज़ाम में बैठते हैं ऑल इंडिया PG, और सीटें हमारे पास. अब ऐसे अच्छी बात है, मोदी सरकार आ गई है. 1 लाख, अब तो मोदी सरकार कह रही है कि 1 लाख UG और 1 लाख PG सीट बराबर सबको मिलेगा. भले लास्ट वाले को एनाटॉमी मिलेगी, मिलेगा सबको. तो ये अच्छी बात है. मोदी सरकार में एक अच्छी बात ये है कि बहुत सारे एम्स बन गए, जहाँ देखो वहाँ एम्स. तो एक अच्छी बात उन्होंने कही कि 1 लाख UG सीट होंगी 26 तक, 2026 में. 1 लाख UG सीट्स, 1 लाख PG सीट्स. एवरीबडी विल गेट अ सीट. and I believe them. It will happen. Already 80,000 UG seats are there, and maybe some 50,000 PG seats are there. So out of 2 lakhs, presently, if you want to screen, the question should be like that. Only 10% students should be able to answer, because that is the scenario. You don't have so many PG seats. So how do you decide? So if that is the quality of question, you will get 1 lakh. Actually now after 20 years you may be getting more. I am not very sure. Okay, a long question again. So as you go through this question, you will notice 5-year-old boy presented 1 week history, general malaise, mild fever, indolence, okay, not very active, anorexia, loss of appetite, 5 year, okay, developed dysphagia, sialorrhea, difficulty opening mouth, thinking of trismus, lockjaw, eventually dehydration, parental concern, refusal to fluid, pediatrician presented trismus already, inability to open the jaw, muscle rigidity, oh this is serious, muscle rigidity, lack of immunization, TT, toenail infection, tetanus toxoid, Clostridia tetani, suspicion of generalized tetanus. This is deadly, the boy may die. Anyway, now anatomy comes. Suddenly the anatomy question comes. So this appears funny sometime, you know, what we were thinking of some treatment management, and suddenly which muscle is doing what. This is a funny kind of questions. Suddenly they ask you anatomy. Anyway, remember, if it is tetanus, Clostridia tetani, going into spinal cord, you know, presynaptic, all that microbiology and all those things, tetanospasmin and all that, acetylcholine blocker and whatever, coming to the head neck region. Now the thing is, you just remember one mnemonic, MTM elevators. There are 3 muscles which elevate the mandible and close the mouth. If you elevate the mandible, you will close the mouth. So MTM elevators. There are 3 muscles which elevate, and there are 3 muscles which depress. If they depress, they'll open the mouth. In tetanus, trismus, lockjaw, you will find that MTM elevators become more rigid, spastic, tonic muscle spasm. What happens in tetanus? In tetanus, there is a tonic muscle spasm, and that doesn't go. Tonic muscle spasm, excessive acetylcholine is there. So muscle goes into spasm. Then you got your answer. It is asking that all the muscles close means elevate. So MTM elevators. So answer is lateral pterygoid, because lateral pterygoid is a depressor of mandible. So lateral pterygoid is a depressor of mandible, and it is to open the mouth, and that is your question. Just briefly, you can look at the diagram as well. Say you are looking at the right mandible. This is right mandible, right side of the mandible. You are looking at the right side of mandible. Now, if this is the right side of mandible, you can also tell this is the condylar process which goes into temporal bone, temporomandibular joint, condylar process, and this is coronoid process. So this is condyle process, this is coronoid process, and you want to attach the muscle. See, all the muscles of mastication must attach to mandible, then only they can move the mandible. So they insert all the muscles which move mandible, insertion. So which muscle insert on the mandible? You will notice that near the angle of mandible, laterally is the masseter muscle, but medially is the medial pterygoid muscle. Medial pterygoid muscle. Means if you remove from here, you remove masseter, then you will find the mandible. If you remove mandible, then deep to that will be medial pterygoid. Basically, medial pterygoid is medial, masseter is lateral. They sandwich the bone, mandible bone. If you remove the mandible bone, the two muscles will come in contact. What do? What they do is they pull the mandible like this. And what is this? This is a vector. So resolve the vector upward and forward. You mean to say they are not only elevators, but they are also protruders. So they do protrusion and elevation. So medial pterygoid and the masseter, they pull in such a vector that you have to resolve xy direction, and in y direction elevator, close the mouth, and they protrude the mandible. Okay, MTM, where is T? Temporalis. Temporalis is here. It is a temporal bone. From there it comes and it inserts here. So you are talking about temporalis muscle. What it will do? Look at the origin and insertion. If that is the origin, this is insertion. What will the vector? The vector will be like this. Okay, if vector is like this, resolve in xy direction. Xy direction, if you resolve, this is y elevator. So it is also elevator, but it is a retractor. It will do retraction. So what will happen if I ask these three muscles to work together? MTM elevators, they elevate the mandible. What about the protrusion retraction? Protrusion retraction might be cancelled. Protrusion cancelled by retraction. So effectively they are elevators, MTM elevators. But lateral pterygoid, if you talk about lateral pterygoid is inserted in the pterygoid fovea here, neck of the mandible. Lateral pterygoid is inserted in the pterygoid fovea in the neck of mandible, and it pulls in this direction, means protruder and depressor. So lateral pterygoid is a protruder and depressor, yes, and it will be opening the mouth. Yes, if you depress mandible, you open the mouth. You told that three muscles are elevator, MTM elevators, three are depressor. Which are depressors? The lateral pterygoid. And what are the other two? Other two, you have to draw the hyoid bone here, which is below the mandible. So hyoid bone is below the mandible bone. Draw the bone and two muscles there. Which two? You see that there is one muscle here, one muscle here. Yeah, but what is their name? Anterior belly of digastric and mylohyoid. So what do they do? Anterior belly of digastric and mylohyoid, they pull the mandible down, depressor. So what are the three depressors? The three depressors of mandible are lateral pterygoid and anterior belly digastric and mylohyoid. Okay, three depressor, three elevator. Yes. What is the nerve supply? All the muscles of mastication develop in first pharyngeal arch. So all the muscles of mastication develop in first pharyngeal arch. So mandibular nerve branch of trigeminal is the nerve of first arch. Mandibular nerve branch of trigeminal is the nerve of first pharyngeal arch. So you mean to say all these six muscles are supplied by mandibular nerve? Yes, actually in the first pharyngeal arch there are 8 muscles developing. 6 are here. 8 muscles developing, 6 are here, then which 2 others are not here? They are called as tensors. What tensors? Tensor tympani, tensor palatii. So they will be also supplied by mandibular nerve branch of trigeminal. Yes. 3 elevators, 3 depressors and 2 tensors develop in first pharyngeal arch. 3 elevators, 3 depressors and 2 tensors develop in first pharyngeal arch. The tensors are tensor tympani, tympanic membrane, reduce the sound, dampening of sound, and tensor palatii. Tensor palatii, tensor tympani, 2 tensors develop in first pharyngeal arch, hence supplied by mandibular nerve branch of trigeminal. Anyhow, what is the answer to the question? The answer to the question, as we look back, we already gave the answer. They are asking tetanus and all the muscles, they elevate the jaw and close the mouth except. So they were asking what MTM elevators. Whoever is not elevator is the answer. You mean to say lateral pterygoid, depressor. A question comes, it will ask you, lateral pterygoids. Sir, lateral pterygoid, the actions are depress the mandible and protrude the mandible. If you have to choose between two, because already there is a question. First answer should be protrusion, and then second answer depression, and there is a third answer also. Third answer, what is the third answer? It actually aims the mandible. It aims the mandible. Aim the mandible. Who is aiming the mandible? The lateral pterygoid. What is this aim the mandible? A, anterior means protrusion, yes. I, inferior means depression, yes. It takes the mandible anterior and inferior, and what is M? Medial. It takes the mandible anterior, inferior and medial. Now there is a case of right-sided trigeminal nerve injury. There is a case of right-sided trigeminal nerve injury, mandibular nerve injury. So lateral pterygoid not working. So you ask the patient to protrude the jaw. Protrude the jaw. So what will happen? If right-sided lateral pterygoid is not working, left-sided lateral pterygoid will become more powerful. So jaw deviates to same side of lesion. Say normally lateral pterygoid, they balance each other, pulling jaw in the midline. If you use both lateral pterygoid, jaw will protrude in the midline. Both lateral pterygoids working together, the jaw protrudes in the midline. What will happen if one lateral pterygoid is not working? Normally they balance each other. If one of them is not there, other will keep working. So the jaw deviates to same side of lesion. Right-sided mandibular nerve injury, right-sided lateral pterygoid not working, the jaw deviates to right side, same way as genioglossus, 12th nerve injury. Tongue, genioglossus aims the tongue. When you say genioglossus aims the tongue, means even genioglossus will take the tongue anterior, inferior and medial. How do you protrude your tongue? Using genioglossus. It not only protrudes, it takes the tongue inferior and medial. What if I have 12th nerve injury on right side? If 12th nerve injury on right side, then right genioglossus is not working, then balancing is not working. So what the left will do? Tongue deviates to same side of lesion in 12th nerve injury, jaw deviates to same side of lesion in mandibular nerve injury. I think I should stop here now. I just wanted to give you an idea that if next happens, which happens next year, you will face such questions, and not only next, it will also be helping in your INI-CET, because already they have started giving you a taste of such questions. And leave INI-CET, FMGE also last year July, if you look at, you found such questions even in FMGE. So means now they are omnipresent, omnipresent, भगवान की तरह omnipresent. अब ये हर जगह मिलेंगे, DNB हो, ऑल इंडिया PG हो, INI-CET हो, FMGE हो, वैसे तो सब हट जाए, सिर्फ एक एग्ज़ाम हो, उसका नाम क्या हो? नेक्स्ट. लेकिन हमारे को ना पूछे, हमसे अगले वाले हमारे जूनियर्स को पूछो. हम 2019 के हैं, हमारे जूनियर भुगतेंगे, हम नहीं भुगतेंगे. जब 2020 आएगा, हमारे जूनियर्स से पूछो, हम तो नहीं दे रहे हैं नेक्स्ट. तो नेक्स्ट जो है नेक्स्ट होता रहेगा, और होता भी रहना चाहिए. तैयार तो हो जाने दो मेंटली लोगों को, उसके बाद पूछो. ठीक है. Is there any trick to remember these muscles? I told you the trick. 3 elevators, 3 depressors, 2 tensors. You have to develop your own tricks also. And if you continuously practice questions, maybe you don't need tricks. Mnemonics are very dangerous, you know, tricks are very dangerous. It's better to remember the information. I usually avoid giving mnemonics or tricks. So I think I should stop here now. I wanted as I told you, to give you just a trailer of the movie, and 2 hours, 5 to 7. So this is where I stop. My best wishes are with you. I just want one thing from you: become a good doctor. That is the only thing I want. And what about these things? Practice as many MCQs as possible. All the best. Take care.